La Escuela de Medicina y Ciencias de la Salud se fundó en Monterrey en el año de 1978, y es ahí donde está el Centro de Innovación y Transferencia en Salud, el Hospital San José y el Hospital Zambrano Elion. En Ciudad de México se encuentra la Unidad de Investigación de Enfermedades Metabólicas del Instituto Nacional de Ciencias Médicas y Nutrición, Salvador Subirán. En la ciudad de Guadalajara, el Centro de Ciencias de la Vida. En Chihuahua, la escuela es parte de Tec Salud, integrándose también el Hospital San José, Hospital Zambrano Elion, institutos y Fundación Tec Salud, formando un centro de atención, educación e investigación. Ser la mejor escuela de medicina y ciencias de la salud de Latinoamérica es nuestra visión, enfocándonos en bienestar, prevención y longevidad. Nuestros programas académicos: médico cirujano odontólogo, licenciatura en nutrición y bienestar integral, licenciatura en psicología clínica y de la salud y licenciatura en biociencias. 17 especialidades y subespecialidades médicas, 30 cursos de alta especialidad, una maestría y 2 doctorados. Nos caracteriza nuestro modelo educativo innovador, creando una experiencia transformadora con alianzas educativas en todo el mundo, 8 grupos de investigación con enfoque estratégico y más de 50 alianzas educativas en todo el mundo. Sociedades académicas para monitorear y apoyar a los alumnos, posicionándonos dentro de los primeros 5 lugares en el examen nacional para aspirantes a residencias médicas. Nuestros programas cuentan con acreditaciones nacionales que respaldan su formación, siendo la primera escuela privada que tiene convenio con la Secretaría de Salud del Estado de Nuevo León, a través del programa multicéntrico. Y somos la única universidad privada en México que figura en el ranking QS de Medicina en Latinoamérica. Ahora que nos conoces, explora, elige, libera tu potencial transformador.
Muy buenos días, tengan todos ustedes. Soy el doctor Oscar Valencia, coordinador de este espacio de educación médica continua. Y antes de dar inicio a nuestra sesión, les recordamos mantener en silencio sus micrófonos. Todas las preguntas las podrán hacer a través del chat y al final de la presentación las haremos llegar a nuestra ponente. También les recordamos nos hagan favor de llenar una encuesta de satisfacción y también tener el nombre en la cámara, aunque esté apagada, pero que tengan el nombre con el que vamos a dar las constancias. En nombre de la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey, les doy la más cordial bienvenida. On behalf of School of Medicine and Health Science, we'll give you the most warm welcome, Dr. Christina Wierenga. Eva, le doy la palabra a Eva para que presente a nuestra distinguida huésped del día de hoy.
Muchas gracias, Oscar. Buenos días a todos. Hi, Christina. Good morning. Thank you for being here. We're very privileged and honored to have you with us. Voy a hacer la introducción de su currículum. La doctora Christina Wierenga es profesora, neuropsicóloga clínica y codirectora del programa de investigación del Centro de Trastornos de la Conducta Alimentaria de la Universidad de California en San Diego. También es codirectora del programa de capacitación en pasantías de psicología en UCSD y recibió su PhD en psicología clínica con especialización en neuropsicología, neurorehabilitación y neurociencias clínicas de la Universidad de Florida y completó una beca postdoctoral del NIH en UCSD en psiquiatría biológica y neurociencias. Ella es experta en neurobiología de los trastornos de la conducta alimentaria y además realiza investigaciones neuropsicológicas y de neuroimagen que examinan la base cerebral de los trastornos de la conducta alimentaria con énfasis en los constructos que contribuyen a la motivación alterada para comer, incluido el control cognitivo, el procesamiento de recompensas, el aprendizaje y la interocepción. A través de la colaboración con las doctoras Stephanie Peck y Laura Hill, ellas han desarrollado y continúan probando un enfoque de tratamiento que se conoce como terapia basada en el temperamento para adolescentes y adultos con trastornos de la conducta alimentaria, que está guiado por una base neurobiológica del comportamiento basado en el temperamento. Ha publicado más de 100 artículos revisados por pares y ella ha tenido financiamientos del NIHM, del NIDDK y de la Asociación Nacional de Trastornos de la Alimentación y de la Conducta Alimentaria, del Departamento de Asuntos de Veteranos, y ocupa muchos puestos de liderazgo dentro de la Academia de la Academy for Eating Disorders. Entonces, bienvenida, Christina. Welcome, Christina, and thank you.
Thank you. It is a real pleasure to be here. I realize I'll be talking about neurobiology and I'll be speaking in English. So I hope that's not too challenging.
Thank you. No problem.
Okay.
Please go ahead.
Okay, let me share my slides. Okay, can you see that okay?
Yes, we can. Thank you.
Okay, perfect. So it is a real pleasure to be here. I have spent my career working with eating disorders in trying to understand the neurobiological mechanisms that drive symptom expression in order to inform better treatments. So all of my work is really focused on trying to better understand why our patients feel the way they feel and act the way they act in order for us to more effectively help them and develop, more effective treatments for this really difficult to treat disorder. So what I will be speaking about today is just an overview of some of the recent advances that we've made in our understanding of the neurobiology of eating disorders, admitting that there is a lot that we do not know yet. And I will provide some demonstrations of how this neurobiological research can inform our practice and our treatment. So let's see if I can advance the slide. Okay, so this is the outline for today's talk. First, I'll present some contemporary models of eating disorders and the neurobiological contribution to the eating disorder presentation. I'll briefly spend some time talking about the brain and how the brain functions and how the brain functions to promote eating behavior, as well as differences that we see in brain function in individuals with eating disorders that provide clues into how brain dysfunction might contribute to eating disorder symptoms. Then I'll address what we call neurobiological treatment targets. But essentially, what I'm referring to here is different functions that might drive disordered eating behavior that we have identified, and then how we can modify our clinical strategies to think about symptom expression from a neurobiological standpoint. So it involves a slightly different way of conceptualizing the behavior that our patients exhibit. And if we think about the neurobiological drivers or underpinnings, it might speak to different methods of intervention. And so I'll introduce some of those clinical strategies. And I'll close with some examples of neurobiologically informed treatment approaches, one of them being our temperament-based therapy with supports that Dr. Trujillo introduced. It is a behavioral intervention that is really guided by conceptualizing eating disorders as neurobiological disorders and using that to provide a rationale and a focus for our individualized treatment interventions. So with that, I'll just jump right in and acknowledge that our understanding of the neurobiology of eating disorders is still relatively new. And it was really sort of prompted by new findings related to the genetic involvement in eating disorders. And so about 25 years ago, longer than that even, studies identified that there was an increased risk of eating disorders in first-degree relatives. So recognizing for the first time that there might be some heritability involved in the development of eating disorders. And then twin studies demonstrated that approximately 50 to 80% of the risk of developing an eating disorder can be attributed to heredity. So it doesn't necessarily mean that it's the same eating disorder subtype that's spread throughout families. But if a mother has anorexia, a family member, daughter or son, it's almost 11 times more likely to have anorexia than an unrelated peer. So this really it set the stage for recognizing that eating disorders, and most of the research has been done in anorexia and bulimia nervosa. So that's what I will be spending most of my time talking about, just because that's what we know the most about. But that for the first time, there was recognition that eating disorders are biological disorders, and to a large degree caused by genetics. More recently, the genome-wide association studies have identified correlations between genes that are associated with some of the psychiatric traits that we see in individuals with eating disorders, as well as metabolic traits, including BMI and fat mass and cholesterol and physical activity level. So this is called for a reconceptualization of anorexia nervosa as a metabopsychiatric disorder. GWAS studies are ongoing right now for bulimia nervosa, but we don't have nearly as much information. But then the question is, well, how do genes actually cause eating disorders? Because there hasn't been a single gene identified like there has for something like cystic fibrosis or Huntington's disease. So how exactly do genes confer risk? And one idea is that genes code personality, and personality traits serve as susceptibility or vulnerability risk factors for developing an eating disorder. And this has come from a large literature suggesting that there are common traits in individuals with eating disorders that are identified or pre-exist or exist prior to the development of the eating disorder. And are maintained to some level even after recovery, suggesting that these are real traits related to eating disorders. And this is what we often call a menu of traits that are common in eating disorders. It doesn't mean that everybody with an eating disorder is going to identify all of these traits, but I share this information with my patients. And I often ask my patients, and I ask their families, how many of you identify with these traits, and tell me which ones. And by and large, most people, most family members and individuals, patients with eating disorders will identify with several of these traits. And these traits include things like anxiety, worry about what might happen, intolerance of uncertainty, and real preference for routine and assuredness, being very harm avoidant and not taking risks, and judging all of the possible risks before making a decision. Cognitive inflexibility or rule-bound, feeling safer with rules and having difficulty shifting behavior, having a hard time making decisions and feeling confident about those decisions. Obsessionality, perfectionism, being highly achievement-oriented and striving for excellence. Having increased sensitivity to punishment, seeing neutral things as more critical, being very sensitive to mistakes, and maybe being less sensitive to reward. And so we'll talk more about each of these as we go on. But the important thing to keep in mind is that these are not necessarily bad traits. In fact, these traits can be strengths. They can promote real success in life, and they can serve people really well. So it's sort of the motto that we take is traits as strengths, and that although these traits might contribute to the onset of eating disorders, they can also support recovery. And so this is a common biopsychosocial model of eating disorders that recognizes that premorbid traits exist prior to an eating disorder. They are biologically determined, passed on by family members, and they can be expressed productively or destructively. And what happens, what's thought to occur, is that there's a perfect storm with puberty, and there's genetic impacts on brain development and hormones, and environmental impacts, including stress and culture. And that combination with this set of traits can increase anxiety and dysphoria and result in dietary restriction, whether it's intentional or not. It may not matter. What happens, though, is that the weight loss becomes very, and this is a model primarily for anorexia, but some of it applies to bulimia. Weight loss becomes very damaging. It actually serves to decrease some of the anxiety, so it regulates emotional experience, which then reinforces it. But with weight loss, it increases neurobiological changes that sort of make these negative trait expressions more rigid, and people end up in a vicious cycle, which unfortunately up to 30 to 50% of individuals with an eating disorder who develop an eating disorder develop a chronic course. The good thing is that about 50 to 70% of individuals eventually achieve recovery. And one notion is that perhaps they achieve recovery by learning to manage these traits. So rather than these traits taking on destructive expressions, they take on productive expressions. And so an example of that might be anxiety, where somebody's incredibly anxious about food, and they translate that anxiety to motivational drive to achieve some non-eating disorder goal in life. But what's really confusing from a biological perspective is that eating disorders reflect a discrepancy between one's physical needs to eat and the motivational drive to eat. So individuals with anorexia restrict food despite feeling hungry. And individuals with bulimia nervosa, when they binge eat, they're eating beyond their nutritional needs. So this really raises a question of, is this the balance between the influence of hormonal signals, signaling energy stores, and then this more maybe hedonic or cognitive influence on eating behavior. And so this is a model that has really informed the way that neurobiology folks think about eating disorders. And we come at it from a perspective of how does the brain and the body control eating, and what might go wrong in somebody with an eating disorder that contributes to the behaviors that we see, like restricting or binging and purging. And so there are two primary systems involved in eating behavior, the gut and the peripheral system, which includes all of the neuroendocrines and hormones that you're all aware of that signal energy stores, send messages to the brain to drive an organism to eat or to stop eating based on their physiological needs. There are cognitive aspects of eating as well, right? So the brain receives these signals about energy stores in the body, and then makes decisions based on these signals in terms of whether to approach or avoid food. And this includes calculating the reward versus the risk of eating, relying on memory and learning from prior eating episodes, and ultimately making decisions about whether and what and when to eat. And so we also know, since this figure is very complicated, we can sort of break it down more simplistically into different circuits of the brain that are responsible for these broad functions. And we can simplify these functions in terms of the reward circuit, which here is in red. And this reward circuit really drives that appetitive approach to eat. When combined with emotionality, it can also promote avoidance behavior. The insula, which we'll talk a lot about, which is really responsible for intraception, which is your physiological sense of your body state. And you can think about how important that is in eating disorders. The insula also receives messages directly from the periphery to indicate hunger and satiety, and then it uses that information to guide, again, sort of approach avoidance behavior. And then the cognitive circuitry, which is here in teal, which really relates to decision-making, inhibitory control, making one choice over another. And as we'll discuss later on, there's a balance between these systems. And maybe when they're out of balance, that imbalance contributes to eating disorder symptoms. So that was just a brief introduction, and I'll start talking more specifically about some of these what we call cognitive constructs or functions. But overall, studies are beginning to demonstrate that eating disorders run in families, so that there's a genetic contribution. Genes cause traits. So several studies show that people with eating disorders share these traits that I listed before, that existed before the eating disorder and may help to maintain the eating disorder, like perfectionism and obsessionality. And then brain imaging studies, which I'll go into more detail, just demonstrating a few of them, show differences in the parts of the brain that are involved in eating in individuals with eating disorders. So together, this sort of suggests a big paradigm shift for the field, in that there are strong genetic and neurobiological causes of eating disorders that we would argue need to be considered when treating somebody with an eating disorder, because they can help target our treatment approaches. And so when I talk about treatment targets, this is how I'll organize the rest of the talk, is focusing on what we've learned so far about anxiety and intraception, or your physiological sense of your body state, reward and punishment, and decision-making, cognitive flexibility, and inhibitory control. So this organization maps onto those three circuits that I just highlighted in the brain. And I'll describe how these circuits might be altered in individuals with eating disorders, and how that alteration leads to maladaptive behavior. So we're all well aware that anxiety is prevalent in individuals with eating disorders. About 40% of adults with anorexia had a childhood anxiety disorder. Anxiety, particularly in AN and anorexia nervosa, is associated with AN, and food restriction is actually anxiolytic. So there's a function to food restriction. Food restriction in individuals with anorexia nervosa is a way of managing anxiety. Eating causes anxiety, not eating reduces that anxiety. And we know that anxiety is associated with poorer treatment outcome. And in fact, some recent research from our lab, which we're submitting for publication soon, shows that by modifying and reducing anxiety in treatment, you can reduce eating disorder symptoms. But if you just focus on the reduction of eating disorder symptoms, it doesn't change anxiety. So it really speaks to the importance of treating anxiety separately, because anxiety contributes to worse outcome, especially in anorexia nervosa. Intraception is probably one of the earliest identified alterations in eating disorders. And in 1982, Hilda Bruch was quoted to say, perception of body sensations is often disturbed in individuals with eating disorders. They do not trust or accurately identify their feelings or sensations. And in fact, we've done lots of studies using self-report measures, things like the Maya, that have also demonstrated that individuals with eating disorders have reduced trust in body sensations, meaning that they don't trust their body to guide their behavior. So eating disorders can be conceived or conceptualized as fundamentally involving disturbances in the experience of one's physical condition. And you can see this in a lot of the GI symptoms that our patients experience, a lot of body image dissatisfaction and disturbance may relate to altered intraception. And the insula is really the part of the brain that is responsible for intraceptive experience. So what might this feel like to somebody with an eating disorder? This is a direct quote from one of our patients. And she said, I have no idea what to expect. I'm walking around blind. I look to others for guidance, because she's not experiencing that internal guidance, potentially from her insula. And so we've spent a lot of time focusing on something that's called an intraceptive prediction error, or a mismatch between what is expected and what is experienced. And so several of you may be familiar with this idea of prediction error, which is essentially an expectancy violation. And it's when what you anticipate doesn't match what you actually experience. And you can imagine that that leads to anticipatory anxiety because your expectations are not informative. They don't predict well. And so if you're unable to predict what's going to happen, that can be very anxiety provoking. And learning results from being able to adjust your expectations to meet what actually happens. So you learn through modifying those expectations to match reality. And if you continue to have large prediction errors, that impairs your ability to learn from experience. So how or what might this look like when you actually study this in the lab? And so what we've done is a series of different studies where you are able to look at the anticipatory response in the brain and the receipt or the actual experience. And so in this example here on this slide, we actually did a study where we administered a soft touch to patients' arms. And we gave them a cue, basically the yellow square, to indicate that a touch was coming up. And then they actually received the touch. And so we could look at brain response to when they were expecting or anticipating the touch and when they actually experienced it. And what we see in this graph is that the patient group, the patients with anorexia are in blue, and they had decreased response during the anticipation phase and increased brain response to the actual receipt of touch in the insula. And the decreased expectancy response in the insula was associated with increased body dissatisfaction and increased harm avoidance, suggesting that this altered anticipatory response is related to symptoms that we see in our patients. So the take-home message is that this decreased anticipatory response might represent sort of an inadequate preparatory response that may lead to anticipatory anxiety and avoidance, and that and that this might also relate to body image disturbance. So what might this feel like to somebody with anorexia? Going back to that quote, this mismatch between what is expected and what actually happens may lead to anxiety because the world then seems like an unpredictable place. It may lead to avoidance behavior, particularly avoidance of food, because again, if what you experience is so dramatically different from what you expect, you probably want to avoid that experience. It may lead to the intolerance of uncertainty and desire for structure that we see in our patients. And this real, again, the world is an unexpected place and you can't predict it. So how do you feel safe? With routine and certainty. As I mentioned, prediction errors contribute to learning. And so increased prediction errors might lead to difficulty learning from experience, which is why our patients might take longer to learn the skills that we teach them than somebody without an eating disorder, and why maybe our approach of refeeding takes a long time for them to decrease their anxiety around meals. And a disturbed experience of one's body, the body image disturbance that we really have very little understanding of in eating disorders. What about in bulimia nervosa? We ran the exact same study in bulimia nervosa, and this time we saw the difference between individuals with bulimia and healthy controls in the caudate. So this is that in the cognitive circuit of the brain. And what we see here is again, sort of an increased response to the experience of touch in the patient group, but also an increased anticipatory response. So this is the opposite of an AN. So in BN, in bulimia nervosa, there's an increased anticipatory response. And that increased anticipatory response to touch is associated with increased harm avoidance. So again, another association between a brain response and the symptom of eating disorders. So to drive this home, it's thought that intraceptive prediction errors, that these prediction errors related to an experience of your body, this mismatch, may contribute to the disturbed experience of one's body that we see in eating disorders. And that in AN, inadequate brain preparatory response may relate to anticipatory anxiety, and perhaps the increased preparatory response that we see in BN leads to dysregulation of changes in physical sensations or body image disturbance. And that we see that dysregulation through binge purge behaviors. Ultimately, this mismatch might lead to anxiety, difficulty learning from experience, and may lead to reliance on external signals. If you have the sense that you can't trust your internal signals, it's much easier to rely on external signals. So from a therapeutic perspective, how can we use this information to help our patients and help families help their loved ones? If you can't rely on internal signals, it might be better to rely on a predictable external structure and meal plan. And of course, this is what we inherently do in day treatment programs and hospitalization programs. But this is also important to translate this to the home environment, to have predictability, structure, routine, rely on advanced planning, and just increase predictability. Okay, so switching gears to the second target, which is altered sensitivity to reward and punishment. And you may see this clinically in your patients that, as we've already talked about in terms of temperament, they may be increasingly sensitive to perceived criticism and high error detection, and you might not see a lot of motivation to seek reward. And the ventral striatum is the circuit in the brain that is largely responsible for reward processing and processing emotionally significant stimuli. And this is the parts of the brain that receive dopamine, which is a neurotransmitter responsible for reward function. And so we know that from across a number of studies of reward processing in eating disorders, that generally individuals with AN experience reduced brain response to typically rewarding cues, whether they're pictures of food or whether they're tastes of food. There tends to be a diminished brain response in regions that we know to be involved in eating, including the insula, which is also the gustatory cortex or the taste cortex, and the ventral striatum. And we see this both in individuals that are ill and that have recovered, suggesting perhaps this is a premorbid trait, although it could also reflect a scar from having an eating disorder. And then we see the opposite response in individuals with binge type eating disorder. So in bulimia nervosa and binge eating disorder, we actually see increased brain response in these same regions that are involved in food reward. And so a sort of increased response, and reward is a very complicated construct, and oftentimes people distinguish between the liking of something, the wanting of something, and learning from reward. And these studies are really focused on liking. There's much less known about wanting, and we're starting to learn a little bit about learning. But essentially, at a very sort of basic level, there's reduced brain reward responsivity to typically rewarding stimuli in anorexia, and increased brain response to typically rewarding stimuli in bulimia and binge eating disorder. Now, what happens in the face of hunger, right? Because what's so confusing and puzzling about eating disorders is, especially anorexia, but bulimia to some extent as well, is that individuals are able to avoid or restrict food even when hungry. And we know from our own experience that hunger is a huge motivator, a huge driver to eat, right? Food tastes better when we're hungry. The animal literature suggests that when animals are hungry, they are more likely to engage in risky behavior and seek out drugs that are rewarding and eat more. And so what we did was we looked at the brain response to sugar water or sucrose when individuals with an eating disorder were fasted, So they hadn't eaten for 16 hours or when they were fed. And what we found was that in individuals with anorexia nervosa, they continued to have this decreased brain reward response to the taste of sugar, especially when they were hungry. So this suggests that hunger does not have that same motivational influence in individuals with eating disorders, which might help explain why they're able to restrict despite biological drives that are sort of physiologically informing them that they need to eat. And we see this again in the ventral striatum and the insula, regions that keep popping up that we know to be involved in eating. So this suggests that there's reduced reward sensitivity and possibly difficulty translating these hunger signals into motivated action to actually drive eating. And again, since we're always curious of how these altered brain responses relate to behavioral symptoms, what we found in the caudate, again, this cognitive circuit, is that decreased brain response to sweet taste is associated with increased harm avoidance. So this is an important point, that decreased reward sensitivity is associated with increased harm avoidance. Now it's a correlation, so we don't know the causation here. Is it that anxiety and harm avoidance is sort of hijacking the reward system? So you're unable to experience reward because you're so anxious? Or is it that this lack of ability to experience reward creates or causes anxiety? And it could be either. But it does suggest that there's actually a brain basis for coding food as risky and for successful caloric restriction despite hunger. You know, and this is consistent with some theories that are proposing reward contamination in eating disorders, where a stimuli that is typically rewarding, such as food, has been associated with something negative, such as weight gain, and now it carries on this negative association and this association of risk. And we're sort of seeing that play out in the brain. What about in individuals with bulimia nervosa? We actually, to our surprise, we thought that we would similarly see differences during the hungry state, especially aligned with, theories, cognitive behavioral theories that propose that hunger sort of precipitates a binge episode. What we found instead was that there was no difference in the fed state in the amygdala, which is part of the brain that's really responsible for emotionality. And instead, typically, when you're fed, the brain's reward response decreases, and that's your stop signal. That's the signal to stop eating because things are no longer as rewarding. And what we see here is that, in fact, in individuals with BN, their response did not decrease in the fed state, suggesting that they may not devalue food reward when fed. And this might contribute to an inability to stop eating once you started. Now, it's important to think about, is this specific to food stimuli, or does this translate to more general reward stimuli? And in fact, there's lots of studies that suggest that it generalizes to other types of rewarding stimuli, such as monetary wins and losses. And in fact, here, what we found was during a guessing game, when patients with anorexia received positive or negative feedback, they were much more sensitive to the negative feedback. So this is consistent with this idea that there's increased punishment sensitivity in individuals with AN. And then people like Guido Frank have started looking at reward prediction errors, so similar to the intraceptive prediction error that we talked about, when there's a mismatch between what's experienced and what's expected. And without going into a lot of detail, essentially what this shows is an expectancy violation, and either you experience something better than you expected or something worse than you expected. And what Guido has found is that there is greater prediction error, regardless of whether it's a positive or negative prediction error in individuals with AN, and that this greater prediction error relates to worse treatment outcomes, so lower weight gain. And then in individuals with BN, he sees the opposite, so reduced prediction error. And again, we've talked about prediction error relating to learning. So this suggests that learning from reward may be altered in eating disorders and altered in different ways, but we're still, this is a sort of a very new area, and we're still learning more about what this might mean and how this translates to learning from experience. So the take-home messages related to reward and punishment are that the brain reward response tends to be decreased in anorexia and increased in bulimia. And again, this is sort of just basic reward sensitivity or reward responsivity or liking. And that in individuals with AN, hunger may not sensitize food reward motivation, so it helps to enable food restriction. Whereas in BN, food reward may not be appropriately devalued after eating. And coupled with reduced inhibitory control, which we'll talk about next, it may contribute to binge eating or an inability to stop once you've started. And we've seen, and we've actually replicated this finding a number of times, that elevated harm avoidance is associated with reduced reward response and anxiety, or reduced reward response and anorexia, excuse me. So there is some association between reward and risk. And that individuals with anorexia have an increased response to loss or an increased sensitivity to punishment, even at the brain level. We see it behaviorally, but now there's evidence that the brain is functioning differently, and that they have increased response to something unexpected. So again, this like sensitivity to something unexpected or a prediction violation, whereas BN, individuals with BN have the opposite response. They have a reduced response to surprise. So what might this feel like? What might reduced reward signaling feel like? Again, I'm sorry that I'm focusing so much on AN or anorexia, but it's what we studied the most. It might feel like it's just not natural or the dominant brain response to eat like individuals that don't have an eating disorder, to easily trust what to eat and to actually find pleasure in eating, especially in a variety of foods. So at some biological level, eating might not feel natural. And so when patients are in recovery and when they're in treatment, we're asking them to do something that might really feel counter to their biological drives, which might contribute to the difficulty that they have around meals. And eating may cause anxiety, not pleasure. So there is this sort of altered coding or contamination where something that for most people is pleasurable in individuals with eating disorders, there actually might be a biological reason for why eating causes anxiety. And we can take this a step further and think that if there's altered reward processing that we're seeing across domains, so it extends beyond food to monetary reward, this might also explain why we see low motivation for treatment and why our patients can be very ambivalent about even seeking treatment, is ultimately that ambivalence might reflect a brain reward dysfunction. So that ambivalence about treatment might in and of itself be a neurobiological deficit. How can we use this to support recovery and to help our patients and their families? We can try to identify external motivators, so things that are important for people. So oftentimes maybe, something like an immediate meal is not at all rewarding, but there is reward seen in long-term weight loss. Now, of course, long-term weight loss is not something that we want to promote, but that does indicate that maybe there are other external motivators that we can identify and use to motivate behavior, with this idea that there might be difficulty with intrinsic motivation. And so we have to sort of compensate for an altered motivational system. And we can address reward processing differences with contingency management. And again, identifying appropriate rewards and consequences. And if somebody's more sensitive to punishment, it might be more motivating to avoid a negative consequence than to try to obtain a positive. So we use this a lot in our treatment planning, of trying to really identify what's going to motivate behavior. And sometimes for some individuals, just the potential of a higher level of care is enough to motivate somebody to complete their meals and programs so that they don't have a negative consequence. Again, really providing structure around meals, recognizing that intrinsically food might not be rewarding. Now, this is a little controversial because there's a big move towards intuitive eating, but what we've just talked about is that interoception and body signaling is altered and reward processing is altered. And so this argues against, at least when somebody's really ill, relying on internal signals to guide eating behavior, and suggests that that it's more effective to have a very controlled environment around food. And recognizing that there's a biological basis for why eating is not intrinsically rewarding. And that just, for a lot of families, helps them understand the emotionality around a meal and recognizes, well, there's a biological component here, and it's not willfulness. It's not the patient's not intentionally willfully not eating their food. And again, recognizing that this lack of motivation for treatment may actually reflect a deficient reward or motivational system. And lastly, I just want to introduce you to this idea that there's some evidence suggesting that the altered decision-making and cognitive flexibility and inhibitory control are also implicated in eating disorders. And so here's another quote from a patient who said, "I get overwhelmed by the decision of what to eat. When there are too many choices, I don't know what is the right one. So I choose not to eat because it's easier than making the wrong choice." And we can hear a lot in this quote. Number one, anxiety, the overwhelming feeling, difficulty making decisions, not trusting, again, this notion of inability to trust one's body and trust one's choices. Perfectionism, I don't want to make the wrong choice. And so I'm going to choose not to eat because it's easier than making the wrong choice. It's better than making the wrong choice. So how can we, as clinicians, help? And one thing that I'll talk about in a minute is reducing the decision-making burden with our patients and giving multiple choices where all the choices are good choices so that they're not stuck in this difficult challenge of feeling like they're making the wrong choice. And so I've mentioned the cognitive circuits that's involved in cognitive control, behavioral inhibition, planning, decision-making. And this primarily includes the caudate nucleus, which is part of the subcortical system, and the dorsolateral prefrontal cortex. And we've seen for decades altered performance in individuals with eating disorders on traditional tasks of cognitive flexibility and set shifting. And what we've seen more recently is altered brain disturbances as well. And so this is a common task, the delayed discounting task, where it's often used to assess impulsivity, but it also measures delayed gratification. And patients are confronted with a question of, do you want a smaller reward sooner or a larger reward later? And impulsive folks tend to pick the smaller, sooner reward, regardless of what it is, whereas people that are more inhibited and are good at delaying gratification tend to choose the larger, later reward, regardless of how large or late it is. And so, not surprisingly, we see that individuals with anorexia nervosa will wait longer for a bigger reward, whereas individuals with bulimia prefer sooner, smaller rewards. And what we see when we look at the brain response during this task is that, similar to earlier studies, the patient group, the individuals with anorexia are in teal here, they have decreased reward response to the likelihood of getting a reward, and increased dorsolateral prefrontal response when making that decision. So increased cognitive circuitry. When asked about food choices, not surprisingly, individuals with AN are more likely to choose low versus high calorie foods. And in fact, they actually activate the habit circuitry when making these decisions, suggesting that it becomes habitual to choose a low calorie option. And we see this in the dorsal striatum. And then the more automatic behavior loop engagement, so the greater the circuitry in this habit loop is, the fewer calories they eat. So again, showing altered decision-making that's associated with altered brain circuits. And then the opposite is seen in individuals with BN, and where there is actually decreased inhibitory control circuit activation during inhibitory control tasks, which has led to this notion of increased inhibitory control in anorexia and decreased inhibitory control in bulimia. And so just to summarize this, individuals with AN tend to wait longer for bigger rewards. They're able to delay gratification, which is not surprising given what we see clinically. Individuals with bulimia do the opposite. And people with anorexia tend to have increased brain cognitive control response during decision-making. People with bulimia have decreased cognitive control brain response. And again, this might be why the potential long-term reward of thinness is more powerful than the short-term reward of eating in people with AN, and vice versa for BN. BN, are more tempted by the immediate reward. And so this has led to this theory that perhaps anorexia and bulimia reflect opposite balances between reward and inhibition, with anorexia characterized by increased inhibition and decreased reward response, whereas bulimia is characterized by an increased reward response and a decreased inhibitory control. And so how do we use this information to support recovery? We can again identify motivating pro-recovery long-term rewards to capitalize on the ability to delay gratification in individuals with AN, offer multiple choices instead of open-ended questions to help decision-making, set clear rules and expectations, and plan ahead. Never leave your home without a plan is something that we tell our patients so that you're not stuck having to make a decision on the spot. So in the last 2 minutes, I'll breeze through this so that we have time for questions. We have taken a lot of this information and developed a treatment that Dr. Trujillo mentioned called temperament-based treatment with supports, and we've applied this to anorexia. And essentially what it does is it builds on strategies with this model that and not everybody might experience all of these deficits, but that you might have 1 or 2 or 3, but that individuals have altered interoception, they have altered motivation and altered greater anticipatory anxiety and tolerance of uncertainty and inhibition. And so we have, as part of TBTS, developed strategies to address each of these areas, including, as I've mentioned, highly structured meals and a highly structured schedule, and developing tailored, personalized motivational plans and contracts, and developing new habits and practices around meals and so forth. So I won't go into the details, but we have several papers out if you're interested in reading about that. The one thing that we do, and that I think is easy, it is easier to translate rather than using the whole TBTS philosophy, is providing psychoeducation. And this is something that any provider can do. And in TBTS, we use psychoeducation to focus on these neurobiological constructs that we're targeting. And with the strategic goal of offering hope and increasing motivation that change and recovery are possible, that the brain is plastic, that we can build new skills and behaviors to change the eating disorder habits, to validate and reduce blame by putting eating disorders in a medical context rather than only a psychological context, and really to inform and insight and awareness into why we're teaching the skills we're teaching, why we're setting up meals the way we set them up. And so it really is a strategic initiative to ultimately instill hope and motivation and engagement in our treatment. Let's see, other treatments that are neurobiologically informed, I'm sure you're well aware of neurosurgery treatments and some behavioral techniques. I didn't want to just focus on TBTS and sound biased, although I probably am a little biased. And with that, I will close with just acknowledging this takes a village to do this type of work, and I am fortunate to work with wonderful colleagues, to have received grant support for this, and to have an amazing clinic where our clinic sort of serves as our lab. And so we're fortunate to be able to have amazing patients that are willing to volunteer and research and really help us better understand eating disorders. So with that, I will end.
Thank you so much, Christina, for this wonderful talk. Muchas gracias. Tenemos unos cuantos minutos para preguntas. Antes de empezar con las preguntas, les quiero comentar que, como les había dicho en las otras sesiones, tendremos el Congreso Mundial de Trastornos de la Conducta Alimentaria y el Congreso Hispano-Latinoamericano en Trastornos de la Conducta Alimentaria en junio del 2022. Nosotros somos los hosts, yo soy el director del comité científico y vamos a tener en el hispano-latinoamericano, estamos haciendo viendo que se traiga un taller sobre terapia basada en el temperamento, que desde mi punto de vista es algo en lo que todos los médicos de primer contacto deben de estar entrenados para poder orientar correctamente a los pacientes y mandarlos a los centros especializados. So, Christina, I have a couple of questions for you. One of the questions that is repeated is if you could give some take-home message about the approach that the pediatrician or the primary care physician should do for eating disorders based on everything you said about reducing anxiety, modulating the dopaminergic response from the brain, and what other guidelines do you think there are take-home pearls for the pediatrician in their consultations, in their offices?
Yes. I think, again, recognizing that eating disorders are biologic disorders that need immediate attention, and that weight restoration is key to treatment and to normalizing the brain, and that there's an urgency to achieve weight restoration, that especially in pediatric populations, as fast as you can intervene, the better, to really prevent a chronic course of the illness. There's medications, but I'm not a psychiatrist, so I don't want to really speak towards the medications, but there might be now there's a rationale for why medications work, because we do know that there's altered dopamine function and other neurotransmitters that I didn't talk about, like serotonin.
Thank you. Apoyando lo que dice Cristina, creo que un mensaje muy importante de lo que dijo es hacer diagnóstico oportuno, el tratamiento lo antes posible. Como en todas estas enfermedades, lo primero es salvar la vida, y un cerebro malnutrido piensa, siente y percibe diferente. Entonces es muy importante esta recuperación. Y hablando de medicamentos, como decía Cristina, más allá de los medicamentos para la ansiedad o cualquier otro medicamento, el principal medicamento para estos pacientes es la comida. Entonces, aplicando lo que sabemos desde la neurobiología, sabiendo que son trastornos cerebrales con un fuerte componente genético, neurobiológico, la comida juega un papel primordial en la recuperación, tanto en los trastornos restrictivos como en los trastornos compulsivo-purgativos. So I just added some few pearls to everything you said. Okay, so I have another question, and it's also regarding about what are some external motivators that are being studied currently regarding everything you said about neurobiology?
Right. So we actually have a worksheet that lists a whole bunch of things that kids and even young adults find motivating. Some things are return to college if you're a young adult, driving, privileges like either earning their phone and technology back, or sometimes kids are motivated by going to a concert or spending time with their friends, doing family events, so getting more time with parents and siblings. But it is very individually tailored to what each patient finds rewarding or wants to avoid, like not wanting to lose their makeup, or having, not being able to wear their favorite clothes.
Thank you. Well, I think we have to close up because it's already time. So thank you so much, Christina, for this wonderful talk. And thank you for being here so early for you. And I'll see you in June.
Yes, I'm looking
Here in
forward to that.
Monterrey.
Thank you so much for having me. It's so great to have so many people here.
Thank you. Gracias a todos. Los esperamos la próxima sesión. El próximo miércoles es nuestra última sesión sobre trastornos de la conducta alimentaria el mes de octubre. Es sobre trastornos de la conducta alimentaria en niños y va a ser presentado por la doctora Montse Grael de España. Esta sesión va a ser en español. Entonces los esperamos a todos aquí.
Thank you very much, Dr. Christina Wierenga. Thank you. It's a privilege to have you. Thank you very much.
Muchas gracias. Thank you. Enjoy the rest of your day.
You too. Thank you. Y muchas gracias a toda nuestra audiencia. Nos esperamos la próxima semana. Tengan un excelente día y felicidades a todos los pediatras porque resulta que hoy es el día del pediatra.